Professional journey. The title of my talk is The Quest for Health Equity, and that's really been a unifying theme of my career, going back, as I'll explain to you, back to my undergraduate days about 40 years ago. And so my path to Michigan, just to highlight how I came to be standing before you today, and this week is special for me because it's the 9th anniversary. November 1st of 2012 is when I joined the University of Michigan as the director of the Institute for Healthcare Policy and Innovation. And it's been a great 9 years for my wife Ann and me here in Ann Arbor, and our kids who are around the country love to visit Ann Arbor. So it's really been great for me professionally and for us as a family. So I'm the grandson of Armenian genocide survivors and grandson and great-grandson of Polish immigrants who came to this country in the early 20th century. I was born in Pennsylvania, grew up in New Jersey, attending public schools, and from there went on to Duke, where I was a pre-med before going on to medical school, but also a major in history and political science. And that undergraduate experience, if there are any undergraduates with us today, either in person or online, I really want to share how important it was for me and how it really set me on the path that I've been on over my time since college. From Duke, I went on to Harvard to complete my MD degree and Master of Public Policy. I completed my residency in internal medicine at Brigham and Women's Hospital and a postdoctoral research fellowship at the Harvard School of Public Health. And then I served on faculty at Harvard for about 21 years before being recruited here to the University of Michigan in 2012 as the first director of the Institute for Healthcare Policy and Innovation. So those of you who've lived or grown up in Boston and Cambridge may recognize that when you spend a good chunk of your life in that part of the world, this is how the world looks to you. And so for me, spending so many years from medical school forward in Boston, Springfield was about as far as I knew, Springfield, Massachusetts as the Midwest, and the rest was sort of a mystery before the opportunity arose to come here to the University of Michigan. And back in 2012, when I was visiting Michigan, trying to decide whether I would join the university here, our former Massachusetts governor, who actually was born and grew up in Michigan, Mitt Romney, was campaigning for president here in Michigan. And he commented, "I love being in Michigan. Everything seems right. The trees are the right height. The grass is the right color. It just feels right." So that was the kind of a guidance that really helped me to decide it was time to move from Massachusetts to Michigan. And so I've been privileged to have the opportunity to lead a great community of researchers and learners, faculty members at the Institute for Healthcare Policy and Innovation. Our mission is to improve the quality, safety, equity, and affordability of healthcare. We do that through promoting collaboration to produce better evidence that policymakers can then use to create impact in the public and private sector to improve healthcare and improve health. We've grown from about 300 faculty back in 2012 to nearly 700 faculty this year. And it's really been a great experience for me working with this talented interdisciplinary community, both our faculty members as well as our staff and our learners, the students and fellows that work with us, to create this new community that our Board of Regents launched back in 2011. So now that I've been here for 9 years, I have a much broader view of the world, a Michigan view of the world, and not that narrow Bostonian's view that I had before coming to Michigan. I do want to say a few words about Alice Hamilton. I think one of the great features of these distinguished university professorships is that we're able to honor an alum or retired faculty member from the University of Michigan who's had a special impact in our field. And for me, after consulting with my colleague Joel Howell, who's a physician and a medical historian, on some of the luminaries in the history of the University of Michigan, I really settled on honoring Alice Hamilton with the naming of my professorship. Dr. Hamilton was one of the early women to graduate from the University of Michigan Medical School back in 1893, and she's really known as a pioneer in the field of industrial medicine and occupational health, essentially bridging the fields of medicine and public health, which is a big part of what we do at the Institute for Healthcare Policy and Innovation, and then bringing in colleagues from across the Ann Arbor campus, other schools, as well as the Dearborn and Flint campuses. And there's also, not only was Dr. Hamilton bridging medicine and public health in her career as one of the founders of the field of industrial medicine, but she also bridges Michigan and Harvard as an important part of my career. And I discovered 2 years ago when I was back lecturing at the Harvard School School of Public Health, that there's actually a bust in the lobby of the Chan Public Health School at Harvard honoring Professor Hamilton. And that's because she was the first woman appointed to the Harvard faculty a little over a century ago, back in 1919. Her appointment was featured in the New York Times that week. But she did face three important barriers that I think we've made some progress from since the time of her appointment. First, she was not allowed into the faculty club at Harvard. She was not allowed to march in commencement. And she was not given any football tickets as a faculty member. And that was very important as a contrast with my experience when I was in the final stages of deciding to come here to the University of Michigan and thinking if everything was set to accept the offer. And my wife, Ann, who's here today, suggested, why don't you see if we can get tickets to the big house? That would be great. And Michigan came through. So I'd like to say, Michigan's on the right side here. And we've enjoyed many Saturdays like many of you at the big house. So to tell you a little bit about my passions in health policy research, I've in my career focused on the effects of race, ethnicity, gender, and insurance coverage on healthcare and health. And today I'll talk to you about two of those areas, particularly my work on racial disparities and the role of insurance coverage in improving access to care and quality of care. And so those have been my other passions. How can we improve the care that we're delivering in our healthcare system? And how can we advance health equity in the process to make sure we have a fair and equitable health system that treats people according to their needs and helps them achieve the best possible health outcomes? And as I mentioned, my professional journey goes back to my days as an undergraduate at Duke and a couple formative experiences I had there as a history major. One was being one of the student leaders bringing together faculty and students on a new residential learning program called the Program on Race and Society. And that program launched in 1981. I was a senior in college at the time. I served as one of the resident advisors living in the dorm with the 30 students, freshmen and sophomore students participating in this program and trying to take a new understanding, develop a new understanding through living and learning together of what race means in our society. At that time, I also completed an undergraduate thesis on black health in segregated Durham in the first 40 years of the 20th century. And in many ways, those experiences that I had as an undergraduate shaped the course of my career in the years since then. When I look back on the field of healthcare disparities research, I really see it developing over the past 35 or 40 years in three distinct stages. When I entered this field in the late 1980s and early 1990s, we were really trying to understand the scope and the magnitude of the problem. Where did disparities exist? For which racial and ethnic groups? In which clinical conditions or parts of the country? That led to an important second phase, which was understanding what are the mediators of these differences, why do they arise, and what effect do they have on health outcomes. And that led to the third phase that I think we're very much actively engaged in now, and I expect will be for the next decade and longer, is now that we understand the extent of health disparities and why they arise and why they matter in terms of outcomes, what can we do to develop effective interventions in both the policy world and in clinical practice that help to reduce and ultimately eliminate healthcare disparities? I also think about a conceptual model of healthcare disparities that I outlined here in a review article a number of years ago, and that is when we think about patients and their individual characteristics such as race, ethnicity, gender, and insurance coverage, those certainly have an influence on the quality of care they receive, as well as a direct influence on the outcomes of their health, particularly related to their lifelong experiences. And those are determined by the communities in which they live, structural factors, what we now come to understand as structural racism, as well as health system factors. What access do they have to physicians and hospitals and healthcare organizations that also determine the quality of care they receive and the outcomes that they experience. When I was beginning work in this field, I was really gratified that some of the early research that I did could contribute to two important national reports produced by the Institute of Medicine, now known as the National Academy of Medicine. The first of these was back in 2001, known as Crossing the Quality Chasm. And this report was a landmark report because it was one of the first to say that equitable care should be one of the core aims of our healthcare system. And then 2 years later, the Unequal Treatment Report was released by the Institute of Medicine, and that took the work that colleagues and I had developed and many others around the country, over 100 studies at the time, that really documented the magnitude of disparities that we had in our healthcare system, particularly by race and ethnicity, and why this was such an important problem for our society to address. That unequal treatment report outlined what we often refer to as the 3 Ds of differences, discrimination, and disparity. When we look at health services in our system, we can often have 2 groups, one getting more services, one getting less, as shown on the left side of this slide. That difference, though, we need to unpack and understand what portion of it's due to clinical need, appropriateness, or well-informed patient preferences, and those would be acceptable reasons for a difference. But where we begin to see a disparity is when we find systemic factors in terms of how